Okay, well, thank you for joining me. My name is Dr. Matthew Fine, and I'm a periodontist from South Florida. And I want to take this opportunity to thank Snoasis Medical to inviting me to this corporate forum session so I can share some of my favorite BioXclude cases, as the topic of tonight's presentation is 15 ways that we can utilize BioXclude to improve clinical outcomes. And so you'll see that there's a huge variety of cases where I'm using BioXclude, from simple sockets to more advanced sockets to ridge augmentation cases, periodontal treatments that we're utilizing BioXclude. And I want you to really focus on not only the techniques that we're using, but specifically how we're handling BioXclude dependent on those techniques that we're using, dependent on the amount of access that we have, dependent on the goals of the procedure is going to determine how we're handling BioXclude. Because for those of you that have used BioXclude, you know that it handles much differently than any other material really on the market. BioXclude is a deepithelialized amnion-chorion barrier that comes with some inborn features that really set it apart from anything else out there. First and foremost, it's immunoprivileged allograft tissue, and studies have shown that it contains over 250 active growth factors that really have the potential to decrease morbidity and increase the predictability of a lot of the procedures that we're performing, from hard tissue grafting to soft tissue grafting to periodontal treatments, where previously we had no membrane or no material that was like this that we could use that would provide all of these advantages. One of the other things that I really love about BioXclude is that studies show that it has as much antimicrobial ability as an antibiotic such as tetracycline. And so we all know how important it is to reduce the risk of infection during a lot of the procedures that we perform. And so to me, this is really an incredible feature of BioXclude that I think doesn't get enough attention. BioXclude is processed through a proprietary process called Purion processing, where they're removing the spongy intermediate layer and they're relaminating back together the amnion and the chorion layers. And so this is really different than any other material that's currently out there. And so that's why I think it's so important that we talk about how to handle this material, as it really loses all of its memory once it gets hydrated. And so it's really important that we understand how to use it, and so that we can really get the biggest benefit from this material. Like I said, it's a dual layer membrane in that it consists of the amnion and chorion layer. But of course, Snoasis Medical has a great sense of humor. And because we know that it really doesn't matter which side you put facing the bone or facing the soft tissue, they put a nice symmetrical smiley face on the membrane, just to remind you that it doesn't matter which side is facing up and which side is facing down. And of course, this membrane comes in just a wide variety of sizes because of all the different applications out there. And on the box, it actually has this life-size diagram to show you, how big the membranes are. And so you can start to get a feel for, how you would use each of these membranes just based on the size. So maybe for the 8x8 or the 12x12, that could be for like small sockets, maybe some sinus tears, maybe protecting a sinus tear before you're doing a socket graft. Those small sizes come in really, really handy. If you're doing a socket graft where you're maybe elevating an envelope flap, you could see where that 10x20 might be really good. And then if you're doing larger cases, or you're using it to protect your lateral window for a sinus lift, then you're going to start using these larger size BioXclude membranes. And we're going to really talk about that in a little bit more detail in just a minute. And so let's start with our first use of BioXclude, which is probably the way I was using this material most often, was for simple socket preservation cases. In this case, we were placing an implant immediately, but we really had no flap elevated. And of course, we know that we could place our implant into that septum and a blood clot will stabilize. But of course, I like insurance, and knowing that there's a material out there that is immunoprivileged that allows me to have some more confidence that my bone graft material is going to stay in place. And you can see here the healing after about 4 months. We have some great bone that's grown over our implants. And I think you'll see that's sort of a common theme. Not only do we have great bone growing over our implants, we really have like no remnants of particulate graft material. And I see this day in and day out with this material. And so specifically, this can be a little bit challenging because we're not raising a flap in most of these cases to perform our socket grafting. Obviously, by elevating a flap, we're removing the periosteum from the bone, we're decreasing blood supply to the bone. And so if we can get our teeth out minimally invasively without raising big flaps, this is a really nice technique to use BioXclude. And so I was taught early on to use this material and to place it with what's called the 2-instrument method, whereby we're going to use a dry instrument to place the material at the site. And then we're going to anchor it with that same dry instrument. And then we'll use a second instrument, which we're going to call the wet instrument, to hydrate the material. So as you can see on this model, we're just going to very, very gently elevate 1 to 2 millimeters on the buccal and the lingual with a periosteal elevator or a micro elevator, just to allow us to have access to tuck our BioXclude. Then we'll go ahead, obviously, after curetting the socket of all soft tissue and granulomatous tissue, we'll go ahead and apply our bone graft material to the socket. And then we're going to use, in this case, a 12 by 12 BioXclude. And you can see how that looks as we place it right over the socket. And again, very, very important, we're going to use this material with 2 instruments. So the first instrument was the cotton plier that I used to place the BioXclude at the site and hold it in place. And then I'm going to dip my periosteal elevator into some sterile saline and just hydrate it. And as soon as you do that, you'll see that it sort of sucks down over the bone graft, and it allows me to be able to just tuck that just ever so gently under that little flap, just to ensure that it stays in place through the suturing and then, of course, through the early healing. There's a lot of different ways that you can suture this, and we'll talk about a couple more ways in a second, but really this is my favorite way to suture these. It's really very simple. I like to call it a reverse figure 8, where we're basically going from internal to external. And so obviously the benefits of that is that we have a very small risk of pulling that BioXclude membrane out of the socket while we're suturing, because we're going from inside to outside. And so there's no specific way that we want to suture these, other than the fact to just really make it easy on you. But I find that doing this internal is really very, very beneficial. We could have just as simply done a figure 8 or a horizontal mattress suture, or maybe just some single interrupted sutures, and maybe would have accomplished that same goal. But keep in mind, when we are suturing in this way, we really tend to be folding down the edges of the flap, which is really nice because it really does protect our bone graft and then the overlying BioXclude. And so you can see here in a close-up view, again, because we're going from inside the socket to outside the socket, we're not worried about pulling out that BioXclude membrane with every subsequent throw. And to me, that really simplified the way I was using this, because prior to this, I would always be trying to raise flaps so that I could tuck this in. Whereas in these cases, I'm really only elevating, like I said, 1, 2, maybe 3 millimeters of the buccal and the lingual to be able to tuck one of these 12 by 12 sizes. And this works really, really very, very predictably. And you can see that here. These cases leaving this membrane exposed is completely okay because it's immunoprivileged and because it's so biocompatible. Of course, what's going to happen over the subsequent 2 to 3 weeks is soft tissue is going to granulate in over the exposed BioXclude. There's some special directions if we're going to be leaving it exposed. We tell our patients not to rinse or swish for about 3 or 4 days. Obviously, they don't want to be brushing this site because it's early wound healing. But we also tell patients not to use Paradex or chlorhexidine or really any other over-the-counter mouthwash for the first 1 to 2 weeks, because we just don't want to disturb it and we don't want to break down that membrane prematurely. Like I said, there's really no right or wrong way to suture these. Some of my favorite colleagues that also use BioXclude have shown on Instagram and other social media, different ways that we can suture this. And so you're really going to use whatever technique you're comfortable with. There's not really any wrong way, but I would suggest trying what I showed you of going inside to outside. That really had made my life a lot easier when I discovered that technique. Resorbable sutures are okay. Probably a longer lasting resorbable, maybe something like Glycolon would be very beneficial here. But we do recommend even 3-0 PTFE or 4-0 PTFE is a great suture to use. Just remember, of course, we have to remove that after about 2 weeks of healing. And so the second way that I'll use BioXclude is a socket where I had to raise a little envelope flap. And so obviously this is actually a little easier in terms of handling a BioXclude because now we have a little pocket or a little flap that we can tuck our membrane in. So this is a great example of where I'll use that 10 by 20. I'll raise a small envelope flap on the buccal, and I'll just tuck that membrane very gently into that buccal space, pack my bone graft material into the socket, and then lay the BioXclude over the top. And you can see the healing in this third picture. This is at about 10 to 14 days post-op. And then, of course, the benefits of leaving this material exposed is that we didn't move the mucogenital junction. And now we have this beautiful band of thick keratinized tissue. And then we did our uncovery. And yes, I said uncovery, even though it didn't look like I had placed my implant. I actually had placed an immediate implant at the time of this extraction. And you can see that it was covered by just really healthy bleeding bone that we actually had to remove with a high speed and some back action chisels just to expose our implant. And so this is really a common theme when I'm using BioXclude is I'm going back to these sites and I'm not seeing really any remnants of any particular graft material, which is for me what I want to see. Just to take a step back, like I mentioned, if you're going to be placing an envelope flap or small sulcular incisions, maybe to get the teeth out that are fractured below the gum line, or maybe just for access in the posterior like this, where maybe it's not as critical that we keep our interdental tissue and our papilla intact. Very simply, we can create a very small conservative envelope flap, just like we're doing here, where we're placing our incisions to the bone and working our way mesially to distally. And remember, you can always elevate a little bit further, one tooth mesial or distal. You can extend it further if you need more access to the depth of the defect for degranulation purposes or to remove infection, or just to get access to tuck your membrane. And we can do that very simply here. And once we do that, it becomes a lot simpler to get this material in place. And so again, I'll use that dry instrument. I'll use the cotton plier basically and get a nice firm grip of it, making sure that it's completely dry. And in that dry state, it's actually pretty simple to tuck that BioXclude membrane under that flap. The trick here is to make sure that the flap is released in a way that allows you to get this membrane in without it folding up on itself. So as you can see here, we can take this membrane and we can tuck it very nicely. And again, notice where my flap elevation was. So the cases where I used this material with this technique where I was having problems was because I didn't fully elevate my flap mesially and distally or laterally enough to be able to hold my BioXclude membrane. And so just keep in mind, if you're going to be doing this, just make sure that you're elevating laterally enough. And that way your membrane will tuck in very nicely without folding over on itself and giving you any problems. The good news is that if it does fold over on itself, there's really no issue from a functional standpoint. It just may make it a little bit more difficult to suture. Because this is immunoprivileged tissue, and you'll see later on, I'm using it for guided tissue regeneration and things like that. There's really no need to trim this material, and it's super safe to leave it, in contact with adjacent tooth surfaces if necessary. And so that's really no issue. Now, just because we can, not cut this material doesn't mean I never do cut it. And I'll show you an example of that in a second. Here we go. So I often will cut little pieces off of this material just because I know that it is so immunoprivileged and it contains all these growth factors. And I say to myself, well, I don't need such a large piece. And there's often a little bit that can be trimmed from the sides. And so what I'll actually do is I'll mix that with my bone graft material. And this might be a little bit of an off-label use, but it's so simple to do. And I can't see any downside to doing this. And you can leave it exposed. Here again, my BioXclude being left exposed with that same suturing technique I've already showed you. And here's the healing at about 4 months. So again, because we're not moving the mucogenital junction, we're not fighting for primary closure, we've actually created all of this healthy band of keratinized tissue. We can create a crestal incision to go back and place our implant. And again, you see complete regeneration of that socket and of that crest with really nice maintenance of that ridge width, which is what we're looking for. And so, talking about 3 different cases that I've already showed you where we're really looking at more simple sockets, here's an example of a little bit more of a complex socket where I considered it to be a wide dehiscence. And again, in this case, we're going to use one of those larger size BioXclude membranes, but we're going to really do the exact same thing. We can place a distal buccal releasing incision if we need to get even more access. In this case, I was very confident that we were able to completely degranulate with only this small sulcular incision around the teeth that were extracted. There was a what I would call a mild dehiscence, so it was maybe 3 to 4 millimeter dehiscence of the buccal plate, but it was relatively wide. And so I'll use this larger BioXclude membrane and we'll tuck it in. And I'll actually do this before I adapt my bone graft materials. I'll tuck in the BioXclude, then I'll place my bone graft particulate material, my Allograft in most cases, into the sockets. And that's when I will go ahead and now use that 2-instrument technique again, just to very gently wet and hydrate that BioXclude right in place, and then just tuck it right over that buccal-occlusal line angle. And then again, not going for primary closure. We'll leave this a little bit exposed if we can, because then we're not moving the mucogingival junction. And it's really that same common theme of going back to place our implants and having this thick band of keratinized tissue to work with. And of course, beautiful, healthy bleeding bone underneath. And you can see here from the buccal view and then the occlusal view that we did really, really well. And it'll be very easy for us to place our implants now in that prosthetically driven position. And of course, in most of these cases, because you're actually leaving things exposed, we're finding that we're having more keratinized tissue later on. And so at the time of implants, I can do a mid-crestal incision and place some healing abutments, and then support that keratinized tissue and ensure that I won't have to do soft tissue grafting later on. Now, this case looks like a simple socket. This is the next utilization of BioXclude that we're going to talk about. But when we start to look closely here, you see you can be very, very happy with that buccal bridge of bone is still intact. But let's take a closer look of what we're actually looking at here is a pretty sizable fenestration defect. And this defect, the nice thing about it is that it's completely within the housing of the bone, right? It almost looks like a lateral wall sinus window. But this defect was the result of a odontogenic infection that really created quite a bit of destruction. So the hardest part of these procedures, of course, is going to be completely degranulating within this defect, making sure that there's absolutely no soft tissue remnants. Once we do that, we can irrigate with some saline. And then we can use our particular bone graft to fill the space, to maintain that space, and use BioXclude over the top. And this is a great illustration of just how to handle BioXclude in these cases where you have the flap reflected. It actually becomes much easier to use because of the lack of memory of this material once it gets hydrated. So in this simulation, I'm just showing this large volume of bone graft material. You place the BioXclude over the top, and once you hydrate it, it will suck down over the edges of this material actually quite nicely. And so this was a cool exercise for me to do on the tabletop, because I see this clinically, have a lot of relevance when I'm treating these larger defects. And so you can see how this case looked after I adapted my BioXclude over the defect. And because I was using this larger size, I believe this was a 20 by 30, I actually had some that I was able to fold over that buccal-occlusal line angle, even though I had that buccal bridge of bone that was still remaining, which was very valuable to maintaining that buccal-occlusal line angle. It's nice that I can encapsulate and cover over that occlusal aspect of the ridge to just keep my bone graft materials in place. Again, we talked about the benefits of not having to get primary closure, and this case is another perfect example of that. I'm trying to remove tension from the flap margins by using a horizontal mattress. It looks like this is more of a Lateral modification of the horizontal mattress, but really all it's doing is it's approximating those flaps. You can see then I placed 2 chromic gut single interrupted sutures just to hold things in place during that early healing. And you can see here at 7 days that there's absolutely no sign of infection. The soft tissue is now granulating in over that exposed BioXclude membrane. And at 4 months, we have beautiful keratinized tissue. We can flap this site open to place our implant, and you see complete defect fill, really almost outside of the housing of the bone. Because we use that larger size BioXclude, we were able to get a lot of bone graft material under there. Okay, and that allows us again to place our implants. And again, take note of how little remnants of any particulate material you actually see here. And here's the buccal view, again, just showing that we really had complete defect fill here, and really, tells me that this material has a lot of indications for some of our larger bone grafting procedures, where previously I would be using, more resilient collagen membranes. And again, this is just highlighting that lack of memory that BioXclude has. And these cases are very interesting to me because some of these cases were actually grafted prior, and we did pretty well. But upon placing our implants, I always am stuck in this decision. Well, I have maybe 2 millimeters of bone buccal. Now I have some autogenous scrapings or some autogenous from even preparing of the osteotomies. And I really hate to have that go to waste. And so in a lot of these cases, I'll adapt that to the buccal plate. And I'll lay a BioXclude membrane right over the top, very nicely. And you'll find that you'll do very, very well with these cases. In any event, most of these cases you won't ever expose later on necessarily. Maybe you'll have a healing abutment in place, but it really does make this a very simple way to do contour augmentation, which we'll talk about in a couple of minutes. Of course, I mentioned this before. For the preparation of lateral windows, I think this is really an ideal material. Just like the case we showed you, these sinus lifts, these lateral sinus lifts, it's a defect that's within the housing of the bone. And so we know that, these sinus lift procedures heal very, very well. And while it is controversial whether or not you need a membrane, over that lateral window, to me, I just really like that insurance of knowing my bone graft isn't going to be, soft tissue encapsulated, and it's actually going to keep my bone graft in place during that early healing. And so this really could not be any simpler. Of course, we have a pretty large flap because we needed access to the lateral window. And so again, we're going to use the benefits of this material by placing it dry, hydrating it right there with two instruments, one to hold it in place, the other to gently hydrate it with some saline, usually using a Pritchard elevator or a Boozer elevator to do that. And you can see right away how it sucks down over that defect. Again, this was probably a larger size, maybe a 20 by 30. And that allowed me to lay that BioXclude over that buccal occlusal line angle. Of course, not all sinus lifts go great. So the next example of how I'm using BioXclude will be just to show you how it really comes in super handy if we do have a small tear of the sinus membrane. You can see in a case like this, we're not doing internal lifts because we only have maybe 2 millimeters of residual bone. And so we go ahead, I'll even use a piezo to perform my lateral windows. And despite using the piezo, we still can get these small tears. And, what I always like to talk about here is once you get that tear, really the first thing you have to do is take a step back here and make your window larger so you have access to work and to continue to elevate that membrane without making that tear larger. And so as soon as I see a tear, I'm going to evaluate the size of the tear, see why I got the tear. Maybe there's a pillar of bone in the way. Maybe there's a vessel or whatever reason that caused the tear. You kind of want to really identify that. And then you want to go ahead and make your window a little bit larger so that you can elevate around that tear. And then at this point, you can use really that 8 by 8 or that 12 by 12 will work really, really well. And you can use that. In some cases, I've had to make my window larger just so I could, fit my BioXclude membrane in there. Because, nowadays I'm really using more of the larger sizes. And so I'll find that what I'll do is take maybe a 15 by 20 and I'll fold it in half. And I just find that why not get that extra protection if the BioXclude membrane is too small. We know how it behaves when it gets hydrated. It loses all of its memory. And so if you place it right over that small sinus membrane tear, in the perfect spot, it will do just fine. But because there's so much blood in the sinus and it's maybe hard to keep it in place if it's just a small piece, I'll go ahead and use the larger one and I'll fold it into two. In any case, you can see how this case healed. And so clearly our sinus membrane healed over the 4 to 5 months that I allowed this sinus graft to heal. And then we were able to go back and place our implants. And you can also see how I had some extra bone graft material that I did use to try to augment some of that buccal occlusal line angle. And even that bone graft material seems to have turned over really, really nicely. And of course, we have some healthy bleeding bone to work with now. So the next way that I'm using BioXclude is socket grafting with primary closure. So I know I just spent a lot of time talking about all these ways I'm using it and leaving it exposed. Well, there are some cases that present themselves where I just feel more comfortable getting closure. This is a patient that's a smoker. She's been trying to quit for a very long time, but she's got a very powerful position at her company, and she does a lot of public speaking, and she just cannot walk around like this anymore. Well, one of the things I noted that she had, plenty of keratinized tissue to work with. And so I decided I would do that same sort of technique we talked about where we make a very conservative envelope flap just to get access to the depth of the defect and to have some space so we can tuck our BioXclude into that space. Once that BioXclude is in place, before hydrating it, I will then adapt my bone graft to that socket and compact it. Obviously, we don't overly compact our bone grafts into the socket, but just to fill the space. And then we'll hydrate that BioXclude membrane with our wet instrument, our Pritchard elevator dipped in saline, and then we can just fold it right over that buccal buccal occlusal line angle, as I've described previously. But in this case, we went ahead and then basically attempted primary closure or close to it without a big periosteal release, but just enough release that I could get some good closure and not have to really worry about the fact that the patient has some bad habits, that maybe they're not the best healer. And you can see here at about 4 months, we can then enter the site again to place our implant. And that same common theme of having very little remnants of any particular bone graft material is something that gives me a lot of confidence that, I chose the right material, the right technique for this case. And here you can see the implant placed. And of course, in this case, we have plenty of keratinized tissue to work with. She started off with good, thick, healthy attached gingiva. And so we can place our healing abutment, move some of that keratinized tissue to the buccal and some to the lingual, and we'll end up with a healthy soft tissue profile around these implants. The ninth way that I'm using BioXclude is to graft wide dehiscence with primary closure. So I just showed you a smaller socket with primary closure. Let's look at a little bit more complex case. This case actually presented with a pretty significant ridge deficiency in the anterior site, in that premolar site. And so I started using a collagen membrane, a cross-link collagen membrane. I stabilized it with sutures, but I just didn't have enough to cover this posterior socket and this posterior dehiscence. And so I went ahead and just used my BioXclude. And because, again, this defect is mostly within the housing of the bone, this is a very easy way to use BioXclude, placing it over the bone graft, hydrating it, and just watching it suck down really, really nicely over the ridge on the buccal and the lingual. And in this case, I, again, went for primary closure, mostly because I was doing more of a ridge augmentation in the anterior site. But nevertheless, I got primary closure. You see the inadequacy of doing and getting primary closure is now we're obviously moving the mucogingival junction, and we have to sort of address this at the next step, where we're either going to split that keratinized tissue and move some to the buccal, or we maybe do a soft tissue grafting case, a soft tissue grafting surgery to augment the soft tissue at the time of implant placement. But you can see once we uncovered how well we did, not only in the anterior site, but in that posterior site where all we used was the BioXclude. And you can see a close-up view here. And this is really the picture, again, that just says it all for me, because I have no remnants of any particular graft material. And this is only 4 months after doing this socket graft. Of course, we didn't grow bone outside the housing. I didn't adapt any bone graft materials to the buccal side of the crest. And so you always will get a little bit of shrinkage, but of course, studies show that by performing socket preservation, we're losing less. And so in this case, we certainly had adequate bone to go back and place a wide 5 millimeter diameter implant to replace this molar. And all we used was that particulate graft and then our BioXclude over the top. Okay, so this is another great usage of BioXclude, and that's for contour augmentation. Of course, this is a very generic term. Contour augmentation can mean a lot of different things to different people, but I'll show you, for me, what it means is I do a bone graft, or I see a new patient for the first time, go to place an implant, I flap it open, I have good bone, I can place my implants, but I can either see through the buccal plate because it's so thin, or I see that I have some threads exposed on the buccal. And now what do? Obviously, we have some great materials out there that can compensate and that can allow us to regenerate what's lost here. But I want to do something that's really, really simple, that doesn't require me to create like a big periosteal release and create all that swelling and morbidity. And so I'll use some of literally the scrapings or the autogenous bone that comes off of my twist drills from preparing my implant. I will adapt that to that buccal defect. I'll lay the BioXclude right over the top. In this case, I did, have plenty of tissue. So we went for primary closure here, and I did bury the implants as the patient was wearing a removable partial. And then at the time of uncovery, at about 4.5 months later, again, we have, complete bone fill of that defect. And you can see we actually have bone over the coronal aspect of that implant that we would remove now with some hand chisels or back action chisels. And for me, this is the best place for me to, start the restorative phase of therapy. Because of course, now we're taking x-rays and we're seeing that we have really stable bone levels. And it gives me a lot of confidence that we have greater than 2 to 3 millimeters of buccal bone now, that this patient can go back to get restored. And at least is starting off at a 0 point and not starting off with bone loss. And I'm using this even for immediate implants. Well, again, using BioXclude, This was a little bit of a tricky socket. It's a tricky space to deal with, not quite large enough for 2 teeth. But the treatment plan was to replace that first premolar with an implant and a single implant crown. And while I had great stability into that socket, I really had a strange anatomy to that buccal plate. It was very, very thin. I could be critical of myself here. I really didn't add enough bone graft material in that posterior aspect of this edentulous site. And you can really see here exactly where I was able to regenerate bone is where I put my bone. But again, bone over the coronal threads of the implant, over that cover screw, and it's not particulate graft material remnants. You can see here it's bleeding bone, and it looks like bone, feels like bone, getting great primary stability. So that gives me a lot of confidence then to use this material even more for cases where maybe I did a large bone graft, like in this case. I got very, very successful results. Soft tissue, maybe there's still a slight defect, but when we flap things open, we have nice, healthy bone to work with. But then what do you see here? Well, I have a lot committed in these cases, right? It's a long process for the patients, maybe 5-6 months of healing from this original GBR procedure. Then I go back and place my implant, and now I'm drilling into my osteotomy. And again, I'm getting autogenous bone for free, basically. So I really hate to lose that. So what I'll do in these cases, I'll just adapt that to the buccal plate. Why not? So easy to do. And you can see very simply here, I can just take one of these smaller membranes, maybe a 15 by 20, and you can really just tuck that under that buccal flap. It protects our bone graft materials, keeps our bone graft materials in place, but of course acts like a membrane, keeps our soft tissue from growing into our bone graft. And you can see supported by our healing abutment, we'll get closure. And then this is the healing at about 6 weeks. And so if you look from the start of the case where we came in with a pretty severe ridge width deficiency, we did our sausage graft with a native collagen membrane, some tacks and screws, and we really overbuilt that defect. But we still have a slight soft tissue defect that we were able to completely get rid of by just using some of that autogenous bone that I harvested while preparing my osteotomies, and then just a small piece of the BioXclude membrane. And I would say that I've kind of changed the way I'm doing these now. I would really just take that 15 by 20 and fold it in half. It just makes it a little bit easier to handle, a little easier to tuck under that buccal flap. So keep that in mind. All right, so this is one of my favorite applications for BioXclude, is in these full arch cases. So whether we're doing overdenture cases or all on X style cases, it's always a challenge for me when I raise a big flap and I'm staring at these very, very large sockets. And even though I'm tabling the bone and that's sort of reducing the diameter of these sockets, I still am left with quite a big jump gap. And to start using a collagen membrane at this point can be a little bit tricky, as they don't drape quite as well. In these full arch cases, I love to just use one BioXclude on either side, and we'll just drape these over the crest. And in this specific case, you see the healing here at about 2 years post-op. They're doing very well. They're keeping them nice and clean. They have some nice soft tissue, healthy nice tissue around the implants. And so this has been an application that I've really started to use exclusively BioXclude for these cases. Here's another example. This is also an overdenture case, but we had some very large sockets. And I just, if I'm in the site, I don't want to miss an opportunity to improve the long-term predictability of a case like this. So we can use one of these large BioXcludes, hydrated at the site. And again, because it loses all of its memory when it gets hydrated, it really does suck down really nicely over the ridge. This case, we have a post-op at about 4 months where we're going to start to do our implant uncovery to start restoring the case. And you can see, without having placed my implants really very deep, I have bone that's now coronal to my implants. And obviously that BioXclude was doing what it was supposed to do. This is another scenario very similar to the one I just showed you, where I'm placing implants after doing all of this alveo, after doing a bunch of extractions. And typically where these teeth are, these canines, is where I want to get an implant in. And so you can see my implant on the patient's left side is completely within the housing of the bone, but it's right next to that socket where I do have probably a 3 to 4 millimeter buccal dehiscence. And it just worries me to not do everything that can be done at the time of this implant surgery to, improve the long-term predictability of the case. And to use a collagen membrane here is a little bit tricky. Like I mentioned, in this case, I could add some autogenous bone right into that socket and just, again, lay my BioXclude, and it'll suck down really nicely over the crest. I don't have to worry about stabilizing it because in these cases, it'll just suck down very, very nicely. Again, you can see the healing here. This is about 4 months, the picture on the upper right. And then now about a year and a half, 2-year post-op, the patient just came in for their maintenance, and I see that the site's, hanging in there very, very well. And I think we had very nice fill of that socket and that buccal defect. And just maintaining the ridge width for the patient, I think, is really the best thing we can do for them long term. And again, this is not a one-off. These cases come in all the time. I don't do as much full arch cases as a lot of you that are probably watching. But these cases can be very, very simple until they're not, until you have a very large buccal defect. And at the same time that we're placing the implants, we go through this long surgery. Do we really want to start doing this large augmentation? When in fact, part of the reason why we're doing all on 4 is because we don't have to do as much bone grafting in a lot of these cases. But I don't feel comfortable with a defect like this around this implant. I can use the particular bone graft material like an allograft. I have plenty of places where I can scrape for autogenous during these all on 4 cases. And then I can, again, just use the BioXclude. And you can see here, this is the healing after about 9 months when the patient came to start getting their prostheses, their final prostheses fabricated. But you can see the health of the soft tissue. We had a little bit of buildup of plaque around the multi-unit, but overall, you can see how we really maintain the thickness in this area, especially which really is going to be a lot more hygienic for the patient as well. And because of the incision design, you can see that I actually use some punches to cover over those multi-unit abutments with the palatal keratinized tissue because of how much alveoloplasty I was able to do. Again, this would be a tricky area to use a collagen membrane because we're really suturing in mucosa up here. Whereas with the BioXclude, I'm not so worried if things open. I have the BioXclude, which I know is very, very biocompatible and can be left exposed, and it'll just granulate in over the top. Here's another more extreme case. Again, a situation where I could certainly turn the blind eye, place these implants with, minimal buccal thickness. But for me, I would much rather overbuild this while I'm in there while I can. In this case, I use mostly a allograft and then just a large BioXclude, get some closure. And again, this is the patient at about 4 months post-op. And I think we certainly were able to regenerate some of that lost ridge width. And who knows, maybe that'll come in handy later on. All right. Well, I do a lot of, I would say, more advanced horizontal ridge augmentation cases. And certainly you could argue for a lot of these cases, some of the best cases, the best results I've had is where I've tried to keep things flapless. But of course, that's not always the case for whatever reason. Sometimes we have to flap things open. And then you start to see things that maybe you didn't want to see, like in this site that's going to be planned as a pontic. We have quite a bit of ridge deficiency there. Certainly a good amount of resorption compared to those neighboring sockets. And then that always just reminds me, well, what's going to happen to these sockets? We're not doing socket shield here. We took out the roots of the teeth and we're left with, a residual buccal plate thickness of 1.5, 2 millimeters maybe. And so in a case like this, I'll go ahead and place my implants. And I went ahead and tried to use a collagen membrane, but it wasn't long enough. It wasn't large enough. So I felt like my bone graft was trying to escape out the sides. And so in this case, I took the largest size BioXclude. And again, I just put it right over that ridge, started hydrating it once it was in place, and it started to suck down very, very nicely. And in this case, because I was working my way around the arch and I really wanted to try to build some bone outside of the housing, I stabilized it with some periosteal biting sutures. In this case, this is just chromic gut sutures. And then you can see I went for primary closure here, and we have some healthy soft tissue that we can work with at the time of implant uncovery. And you can see here, what we're looking at here is, a complete defect fill, regenerated bone, probably 5-6 millimeters buccal to those implants now. And this is really a common theme that I'm seeing when I'm starting to use this amnion-chorion membrane as an adjunct to a collagen membrane. And so you'll see the before and the after. The defect fill is really what gets me. The fact that I have this nice, healthy bleeding bone, again, with no remnants of any particular graft material, it started giving me the idea that maybe for my more challenging cases, I might be better off using two membranes, a collagen membrane and an amnion-chorion membrane. And here's just another example of that, a very large defect where, previously I would have been really apprehensive not to use screws and tacks, maybe even consider using some titanium reinforced PTFE. In this case, I'm using a resorbable collagen membrane with the BioXclude over at the top just to help keep things sucked down. And for me, it really makes the process of stabilizing everything with sutures a little bit easier, because a lot of the collagen membranes don't really want to suck down quite as well, especially for these large defects around the arch. Whereas in a case like this, you'll see the BioXclude is just holding things down. It allows me to suture. And this is at the time of implant placement at about 6 months post-op. And we had a pretty significant increase in the ridge width. We've grown bone outside of the housing, not only on the buccal, but also on the lingual, because I had that second membrane to help me keep everything in place. And so even in cases now where maybe I have a big enough collagen membrane, and this is only a tooth site defect, two adjacent teeth that are missing. You see the maxillary central has a very severe buccal dehiscence. The lateral site, much less severe, mild buccal dehiscence, but there's also a fenestration defect. This is a situation where previously I really would have steered away from placing implants immediately. In this specific case, we were little bit of a time crunch, and the patient's a great patient and really wanted me to try to get as much done as possible for some other things that were going on in the patient's life. So I decided, if I'm going to do this, let me use every weapon I have. So I used my collagen membrane. I used the BioXclude over the top. In this case, we went ahead and got primary closure. Again, because I'm doing so many things at one time and trying to really regenerate that lost buccal occlusal line angle, I feel better about keeping things closed. Of course, sometimes, the best plans go to waste, and you can see here that things started to open a little bit. But of course, because I'm using this, BioXclude membrane with this great ability to be antimicrobial, and also the fact that it's ingrained with all these growth factors, over 250 growth factors, it gives me confidence that even if it opens, it's still going to do very, very well. And you can see here at about 4.5 months, we're ready to uncover our implants, and we place our crestal incision. In this case, you can see I actually was doing a little roll technique, taking some soft tissue from the palate just to move that mucogingival junction back to where it was supposed to be. But when you expose the implants, you can see here we've clearly regenerated completely that buccal occlusal line angle of the anterior implant. And at the posterior side, of course, we have bone, over those implants. We remove that bone to expose our implants, and again, complete regeneration and no remnants of any particulate material. So I think this is really a very nice combination, and started to kind of use it probably a little bit more now, so that I'm seeing these results and seeing how they're holding up over 3, 4, 5 years out. Here's a case of a socket. Again, another compromised patient medically, not a smoker, but just got a lot of other things going on. And so I went ahead and used a resorbable collagen membrane with the BioXclude. In this case, what I'll do is extraorally, I'll actually place them together, make sure that they're sized, and then I'll tuck them together into that space between the buccal flap and the buccal plate. And once those are in place, I'll pack my bone graft into the material. You can see it's some really good bleeding here. And then that material, actually, the BioXclude and the collagen membrane got hydrated very quickly in the patient's blood because of how much heme there was. But again, because it was tucked into that buccal, it really stayed in place nicely. And then I could fold everything over that buccal occlusal line angle and tuck it under the lingual flap and do very, very well. And hopefully, if you'll follow me on Instagram, I'll show you that case coming up soon. All right, now let's talk about guided tissue regeneration, a topic that really isn't quite as sexy these days, but these cases are still out there. And in this specific case, the patient presented with a lateral periodontal cyst that we learned about from the biopsy that was taken at the day of the surgery. But the goal at the time of this surgery was not only to biopsy, but also to regenerate what was lost, since I had to be in there. And so you can see here, I had to be a little bit creative with my flap design. I actually placed the interdental incision in this area on the lingual side, and then moved that entire papilla to the buccal, got access to this defect, was able to completely degranulate it. And I know it might be hard to see here, but I actually had a fenestration in the lingual plate as well here. Okay, so of course, the most important thing with these procedures is to completely degranulate, to enucleate this completely. Some good irrigation in there just to make sure everything's nice and clean. And then I'll pack my bone graft material into that defect. And then what do? What membrane do I use? Well, this is a very tricky area because the interdental space is so small. It's very difficult to have a membrane lie in there flush and really be able to make its way from that buccal side to the lingual over that lingual plate defect. So again, using BioXclude comes in really, really handy because we don't need to trim this membrane, and it's okay if it's in contact with adjacent teeth. And so for a defect like this, it really worked out very, very nicely, placing it on the buccal, and I'm able to use an instrument like the back end of a boozer or any other periosteal elevator to just tuck that in between the two teeth on either side of the defect. And then with some simple suturing, this is just glycolon single interrupted sutures. You can see the lingual incision that I had mentioned earlier, where I just placed one little crestal incision and moved all of that papilla to the buccal to try to minimize how much shrinkage I would have in this area. And you can see we did quite well. This is the healing at about 3 to 4 weeks. And there's the buccal shot at 3 to 4 weeks, showing that we're doing very, very well in terms of the height of the soft tissue. Of course, whenever we're doing regenerative procedures and we're raising soft tissue, especially when the patient was already presenting with this pathology, it's not unusual for us to get some more shrinkage and have those black triangles open up more. But what you'll see here from the pre and the post-op is a pretty significant improvement and a very easy procedure for the patient with very little pain and discomfort after. And I really do owe some of that to the immunoprivileged nature of BioXclude. In terms of traditional GTR procedures, of course, most of us aren't doing nearly as much of this as our predecessors were doing 20, 30 years ago. But every once in a while, these cases do present themselves to my clinic. And in this case, this is a beautiful girl in her mid-20s who really just got a unlucky unlucky situation handed to her here, mostly genetic, but of course there's some environmental issues going on. But she just has localized severe periodontal disease in this area. And while, part of me wants to tell her to take these teeth out, let's replace them with implants, I know that's not a free ride. And so if I can try to hold on to these teeth for her for a couple more years, I think she's going to be in a much better scenario. I ended up putting a little lingual splint on here just to reduce the mobility. I'll do flap elevation, traditional gum periodontal surgery, osteosurgery to reduce the depth of the defects and remove all local etiology and refreshen those roots. But then in this case, I decided, even though these defects were very irregular in nature, there was some angular component to each of these defects. I will use my particulate bone graft material, and then just really a great indication for BioXclude, again, is these GTR procedures where you have very little interdental space. I don't need to trim this membrane. I don't need to secure it. And it will, suck down over the defects very, very nicely. So in this case, I used probably a 15 by 20 BioXclude, but I cut it into a couple different pieces, and I was able to lay 1 or 2 pieces on the buccal, and then also had a couple of the pieces from the lingual, and basically will overlap the buccal and the lingual pieces right under that contact point, just to try to ensure that my bone graft material stayed in place. And this was an interesting case that I have about a year and a half post-op radiographs, and she's doing very, very well. I need to get her back in. It's been a while since I've seen her. Hopefully she's still doing well. But this is really an exciting usage of BioXclude, because this is a procedure that a lot of us have gotten away from because of how challenging and technique sensitive these guided tissue regeneration cases actually are. Here's another example of pathology, also a lateral periodontal cyst here, a pretty large cyst in this case. And you can see when I flap this open, we have quite a bit of destruction, not only interdentally, but the buccal line angles are completely blown out. And so again, we spent a lot of time denucleating these areas, irrigating, making sure there's absolutely no soft tissue remnants. I will use in this case, a demineralized allograft. And then again, I'm going to use that combination of a collagen membrane because it provides a little bit of stiffness that gives me more confidence for maintaining space. But then I want that BioXclude over the top for that immunoprivilege properties, those antibacterial properties, and all those growth factors. And you'll see the healing here. This is the closure right after surgery. And now this is about a 4-month post-op. Took a new x-ray, and I was very, very happy to see how this area had maintained itself, over those first 4 months of healing. And so, we've shown you just exactly 14 different ways of using BioXclude. Of course, there's so many more great ways to use BioXclude. One of the things that you'll see every once in a while is just a random case of a patient who had, posterior mandibular teeth extracted. Of course, the lingual bone could be very, very thick. It's very avascular. Sometimes the soft tissue over the top of that could be very, very thin and is prone to dehiscence, following tooth extraction. And in this case, the tooth was extracted by a previous doctor about 4 months prior to her coming to see me. And it was just a nagging injury. It was very painful because, of course, the tongue is always touching that area every time she eats. It was very, very uncomfortable for her. And there's not really a lot of great solutions here because even if we try to create a bleed here and try to make it bleed, the tongue, of course, is always just rubbing that blood clot really right off from the area. Well, the patient was scheduled with me for an implant. And so once I elevated the flap, I actually thought to myself, well, why don't I use BioXclude? I'll fold it up and I'll actually tuck it under that flap just to protect the bone. I did make the bone bleed a little bit, as you can kind of see here, and then tuck in the BioXclude under that soft tissue dehiscence. And the patient's doing very, very well. And it just gives me the confidence now that that site will epithelialize over. Here's another indication where I'm starting to use BioXclude a lot more. I typically will use a lot of periacryl on my donor sites for soft tissue grafting, but why not, use BioXclude as opposed to some resorbable collagen material like a gel foam or a collet tape, because this material, again, has all those growth factors. So I will basically use a dual layer of the BioXclude. So I'll take like a 15 by 20, I'll fold it in half, and I'll make sure that it's fitting, like a puzzle right into that donor site. And then I'll use some chromic gut sutures just over the top, just to hold it in place. So just 2 or 3 sutures. And then I'll put the periocurl right over it. And you can see here that here's the healing at 1 week. Because we're using, number one, a deepithelialized graft in most of my cases now, patients are doing, much better than they previously were doing. But now that I'm putting the BioXclude over the top with the periocurl, so it's really protecting the site, I'm finding patients, almost aren't complaining at all about discomfort from the palate. It's really become a much more minimally invasive type of procedure than it had been previously. And so, what I want you to take home from this procedure is certainly this is a material that has tons of different applications for regenerative dentistry, but there's all these other procedures that are out there that we come across, like the exposed bone or when we're harvesting soft tissue grafts, where there is a big benefit to using this immunoprivileged material with all these growth factors. And I started trying to list all the different ways I used it, and some of the ways that I've been dying to use it. I really haven't had a really great opportunity that I've seen other people use, or for plastic surgery. For any of you out there that follow Vinay Hyde Perio on Instagram, he's doing some amazing cases with soft tissue grafting, coronally positioned flaps with BioXclude. If you're an oral surgeon and you're dealing with a lot of wisdom teeth close to the nerve, it's probably a great idea to use the BioXclude to help protect the nerve and even do nerve wraps with it. And what I'm really excited about as a periodontist is a bunch of new studies coming out showing the use of BioXclude for non-surgical periodontal therapy. So just a great antimicrobial benefit of using BioXclude for just, of course, a wide array of cases. And so I think, what's important to consider is that dependent on how you design your flaps, dependent on which technique you're going to use, that's really going to drive how you're handling the material. But in general, just keep in mind that the material really handles much better when it's dry. So you want to keep it dry until it's in its, final spot where you really need it. And that's when you can go ahead and hydrate it at the site, and use the benefits of the draping ability of this material. For those fenestration defects, for the lateral windows, it works really, really great. And for contour augmentation, I think that's something that we certainly have to make that decision day in and day out. How are we going to just get that patient the most predictability possible? And for me, part of that is taking every opportunity I have to try to regenerate as much bone as possible. So even if it's only a deficiency of 2 to 3 millimeters, why not do that at the time of implant placement if I have a simple way of doing it where I don't need to, start creating big periostea releasing incisions or doing any fancy stabilization. I can use the properties of the BioXclude to keep that bone graft in place. And of course, because it is cell occlusive to soft tissue, it protects my bone graft, allows my blood clot to stabilize. And what you're seeing in all of my cases is really healthy bleeding bone at the time of exposure or uncovery with very little remnants of particulate graft. So keep in mind that there is a learning curve, just like with any material. But hopefully with some of the tips that I showed you, I think it'll make it a little easier for you next time you pull this membrane out and you pull this material out to use. So I can't thank you enough for joining me, and thanks Snoasis Medical enough for inviting me to speak at this corporate forum session. I hope that it was informative and that you've decided maybe throughout this presentation that there may be some other uses of this material that you've never thought of, or that you've been trying to find cases for, and hopefully maybe I've given you some inspiration. So thank you so much for joining me, and I will see you next time. Thank you.